So, good evening, madam. I, Shuman, on behalf of Shield Healthcare, welcoming you all in today's webinar. And the topic of the today's webinar is menopause treatment and what's new. And the guest speaker is Dr. Aabidha Parveen, madam. And before moving into the webinar, let's have a look on our Shield Connect page. This is our Shield Connect page. Here you can find different blogs written by many eminent doctors in different topics. These are our past webinars. Already we have conducted very many webinars in our platform, and these are the few of them. This is the most important blocks in our COVID era time, and this is the respiratory immunity blocks. And this is our PCOS awareness blog. Here you can find different talks related to the PCOS only in different regional language. You can see that Hindi, English, Telugu, Kannada, and regional languages are available in this. And the most important one is our key opinion leaders. And you can find that almost 250 to 300 doctors are currently supporting us in this knowledge sharing platform. And now it's time to start our webinar. And it's my honor to introduce you, madam. And although madam has lots of awards and credits to her credit, I am just briefing few of it. Madam is the consultant obstetrician and gynecologist, sonologist, infertility specialist, certified lab surgeon at Crescent Multi-Center Multi-Care Clinic and Nillai Multi-Care Clinic. Madam received Dr. N.S. Chandra Bose Award for the best outgoing student in clinical medicine in the state of Tamil Nadu in 60th annual conference of IMA in 2006. Madam received silver medal in biochemistry medal exam in 2002. Apart from that, Madam has many awards to her credit, and out of that, Seva Ratna Award from Social Trust in Milpalayam in 2017, Maposi Award for Best Health Articles in 2017, Karpaga Virucham Award for Best Social Service in 2018, Kamban Award for Contribution to Tamil Literature in 2018, Best Doctor Award from Rotary Club of the Tirunelveli Suburb in 2018, Samugai Selvai Semmal Award from ex-minister H.V. Bande from South India Social and Cultural Academy in June 2019, Seva Ratna Award from the Ungal Nanban Monthly Magazine in 2019, and apart from that, Madam has many international and national papers as well in different journals of well reputation. With this short introduction, I request Madam to take over the session, and meanwhile, I request all the participants to please post your queries on the QA section on the dashboard of Shield Connect page, and once the talk will be over, then we shall have a short discussion on this topic with Madam. So thank you, Madam, and over to you, ma'am.
Good evening, sir. It was such a kind and nice introduction. Thanks for your introduction. And I thank Shield Connect for giving me this wonderful opportunity to talk on a very nice topic of newer treatment of menopause. Can I share my screen?
Yes, madam.
Yes. Is the screen visible, sir?
Yes, ma'am.
So I'm given the topic of like a menopause treatment. What's new? So many doyens in this field have talked about menopause. There are so much to learn about menopause because still we are seeing solving all the mysteries of the menopause. So coming to the topic, actually we used to tell tooth fairy like baby fairy. So there is also a thing called menopause fairy. At first she steals your figure, then she steals your sleep, next your mood, your patience, your eyesight, and finally she eats your brain. That's the most important thing. And all she leaves you with is a lousy mustache, a muffin top, hot flashes, itchy skin, 10 million moods, a dodgy memory, and an endless need for naps, coffee, wine, and cups. So it's not just tooth fairy, there is a menopause fairy too. So what is menopause? Menopause is a normal natural event defined as the final menstrual period, confirmed after 1 year of no menstrual bleeding. So it represents permanent cessation of menstruation resulting from loss of ovarian function, usually due to aging. So coming to the menopause naturally occurs spontaneously. Like the age of menopause varies in different ethnicity, different countries according to the culture, genetic makeup. But some women may attain menopause prematurely due to medical intervention like bilateral oophorectomy, chemotherapy, or at any time due to impaired ovarian function. So coming to the menopause prevalence in India, actually there are many women. The longevity of the women have increased, but the menopausal age remains the same. So in an average in India, 730 lakhs women are in the menopausal age, but only 5% of them are getting treated. But actually, 20% do not show any symptoms. 60% will have milder symptoms, and 20% will have moderate to severe symptoms. They suffer from severe symptoms. Out of all these women, only 5% of them are getting treated, and they are coming to seek treatment also. So how women view menopause? Actually, midlife women, when they go in for a menopausal transition in a perimenopausal period, they usually do not give their complaints. They rather take it as a normal developmental phase. But in some situation, it is okay. But when they suffer severe symptoms, they should not go on like that, because that will affect and impair their quality of life. So 51% in early postmenopause said they were very happier and more fulfilled than in their 20s, 30s, or 40s. It is because of their burden on their livelihood, burden on their life would have taken, but still they will be suffering with symptoms. So about 75% of women making some kind of lifestyle modification at menopause. Either they retire, they will not have much burden of going to work and managing the family. Most of their children would have got educated and got settled, so they will be leading a happy life. So because of their mental makeup, they try to cope up with the menopause with some kind of lifestyle changes. But women with negative attitudes towards the menopause report more menopausal symptoms. So it is perfectly a natural process, but the family members and friends should know, and they should actually support the women, so that they will treat them as normal and natural, and they should support her well, so that they should not make up her like a crazy woman. So as we said, what are all the changes that can take in menopause? One thing is, around the years of menopause, there is decline in estradiol levels. Similarly, when there is a dip in estradiol, the FSH level increases. That's why all the symptoms occur. So when there are many classification. One such classification is straw classification. But when we go through the stages, menopausal transition, it is like perimenopause. It varies from like 2 to 6 years before menopause. And there is a thing called menopause, where there is permanent cessation of menstrual activity for the 1 year, and postmenopausal period. So, as we said already, the age at menopause has remained constant while the life expectancy has increased. So, it is the burden on the women to live with that menopausal symptoms for a longer period rather than a decade or 2 decades ago. So, what all happens in menopause? What are all the internal changes, hormone levels, changes at menopause? One is there is decrease in circulating estrogen, decreased ratio of estrogen to androgen, decreased sex hormone binding globulin secretion, increased peripheral aromatization of DHEA to estrone, and there is reversal of estradiol to estrone ratio. But there is no significant change in testosterone level. So, why is this important? Because there are some receptors in all the reproductive organs and some non-reproductive organs also. So, estrogen has a major role in the reproductive period. One thing is, in the breast, it helps in healthy development of breast tissue. In uterus, it repairs the endometrium and prepares the uterus for fetus development. In urogenital system, it helps to maintain a lubricated vagina and maintains the integrity of the urethral epithelium. And in non-reproductive organs, it has a role in brain. It helps to maintain psychological well-being. It regulates the cholesterol metabolism, maintains the high right ratio of LDL and HDL. In vasomotor, it regulates the normal temperature and perspiration. This is more important because many women will come with symptoms of hot flashes. Liver, it helps to regulate the fat metabolism and distribution. That's why in menopausal women, the cholesterol ratio gets altered. There will be increased hypercholesterolemia and increased risk of heart disease. It helps to maintain bone mineral density. That's why in menopause, they go in for osteoporosis. Skin, it helps in collagen synthesis and maintain the skin integrity. So the estrogen has receptors are there in reproductive as well as in non-reproductive organs. So when we see the estrogen utilization in the target tissue, actually there will be 60 to 70% utilization for reproductive function. Only 30 to 40% will be utilized for non-reproductive function. So, as we have said already, all the location of estrogen receptors in different areas. So when it affects brain, that's why we get hot flashes, insomnia, irritability, mood disturbances, and dementia. So it has its receptors in breast and eye. It leads to macular degeneration, genitourinary tract. So that leads to vaginal atrophy, stress incontinence, dyspareunia. Heart and blood vessels, there will be increased incidence of cardiovascular disease in the menopausal period. And liver, it alters there will be adverse changes in lipid profile. Ovaries, there will be follicle depletion. Skeleton, there will be osteoporosis, and skin and hair will have skin atrophy. So when estrogen gets depleted, all this function will get deranged. That's why all the menopausal symptoms occur. So what are all the we have short and long term symptoms, and the estrogen secretion declines over the years, at the age of 50 to 55 years, and it still remains at the lower level. We get all the symptoms. First, there will be hot flashes, mood, sleep, or acute cognitive changes, urogenital symptoms, and there will be skin atrophy, cardiovascular disease, osteoporosis, and cognitive decline. That will be long-term consequences. So there will be development of subclinical chronic diseases in these periods. So when we come to see the symptoms of menopause, there is a index called Cooperman index, where we have they will exhibit symptoms of vaginal dryness, hot flashes, night sweats, paresthesia, insomnia, nervousness, melancholia, dizziness, fatigue, arthritic pain, formication, palpitation, and headache. So, for us clinicians, we should have a 4 strategic steps. We have to know it's not the treatment will be same for same women. What they have practiced in US, we should not practice here. So we should know the cultural difference in the menopause, self-awareness of cultural competent care, and adopt culturally competent care, and no resources available to help those women. So we should follow these 4 strategic steps to address the problems of menopausal women. So coming to the treatment rationale, the root cause we have said it is estrogen depletion in reproductive organs. So one thing, we have 3 options. One is strong estrogen we can recommend with hormone replacement therapy like HRT. Or option 2 will be weak estrogen, that is soya. That will address some of the problems but not entirely. It has very low effect on estrogen. And option 3 is non-estrogen regulator, which is safe, which doesn't have the risk factors of HRT, and it is highly effective than weak estrogen like soya. So when we, as majority of the women complains of Vasomotor symptoms, so we have varied options in treating Vasomotor symptoms. First and foremost will be hormone therapy. So either it can be estrogen or progesterone, or combined estrogen and progesterone, or non-hormonal prescription like clonidine, selective serotonin and norepinephrine reuptake inhibitor like paroxetine, venlafaxine, escitalopram, and Y-aminobutyric acid analogs like gabapentin and pregabalin, which will address the neuropathic pain also. Non-prescription medication can be isoflavone supplements, soy products, black cohosh, and a variety of herbal medicine formulation. So what women adopts in reducing this vast amount of symptoms is they reduce the body temperature, they maintain a healthy diet pattern, maintain low BMI, they can stop smoking, relaxation techniques, they can practice yoga and acupuncture, they'll have handheld fans, water sprays, increased fluid intake, increased fruit intake. So these are all the lifestyle modification one menopausal women can adapt. So coming to the next foremost problem will be osteoporosis. So what are all the options for the treatment of osteoporosis? One, it can be hormonal, as we have discussed already, like estrogen, HRT can be given, conjugated equine estrogen, 17-beta estradiol hemihydrate, estradiol valrate, tibolone, or estrogen with progesterone. Or other anti-osteoporotics like calcium, vitamin D, SERMs, raloxifene, soy isoflavones, bisphosphonates, alendronate, and risedronate. And another option can be non-hormonal estrogen regulator, which is estrogen. So having said all the options of menopausal treatment, hormone therapy, what we know today, this is more important when we have to address complaints of menopausal women. HT formulation, we have variety of routes. We can give oral formulation, vaginal formulation, like gels and creams, injections we can give, lubricant creams we can apply. So the route of administration, timing of initiation produces different effects. Transdermal route actually carries low risk of thrombosis, but when we give us oral or like injectable forms, they carry a high risk of thrombosis. So absolute risk of hormone therapy in healthy women are low, but can include thrombosis, stroke, cardiovascular events. So always when we start hormone therapy in older women, that is more than 50 years, it carries really a greater risk. Breast cancer rate increases with progesterone therapy beyond 3 to 4 years. So endometrial therapy can be considered for long duration because it carries a lower risk for breast cancer. But when we have to combine, there is increased risk of breast cancer. So we have to consider each women's priorities and risk factors prior to initiating the hormonal therapy. So when we are going for a progesterone treatment, with, as we have said already, like breast cancer risk increases with progesterone use beyond 3 to 5 years. So we are not clear because when we did a study of women's health initiative, like the study is initially aborted because of there are variety of complications we have encountered. That's why like the studies like stopped in between. Actually, the basic mechanism is increases the breast cell proliferation, breast pain, mammographic density. There is a huge burden on the women, economic burden with the repeated mammograms and breast biopsies. So, apart from all this, this progesterone therapy itself can impede the diagnostic interpretation of mammograms. So, but after a cessation or like the increased breast cancer declined only after 3 years of discontinuation of progesterone treatment. So breast cancer mortality was higher when we have given the hormonal therapy. And duration of use. So when it is like potentially when we are following it for 3 to 5 years, there is always an increased risk. And if even if it is started in the early menopausal period, also there is no actually there is a decrease in breast cancer when compared to like more than 50 years women. And when it is started early, like in the menopausal perimenopausal stage, the risk of heart disease is lower. So it is acceptable for women who request it and they are aware of all the risks involved. And there is a prevention of osteoporosis for women at high risk of osteoporotic fractures. When alternate therapy, when we are not having any alternative therapy, so when we have no other options, we have to start on hormonal therapy, provided we should inform all the women about the risk involved. So even after 3 years of progesterone discontinuation, the rate of CVD, fractures, colon cancer remained as the same. So there is not huge benefit when compared to the risk involved with the hormonal treatment. So it became like all cause mortality became neutral. 50% chance of Vasomotor symptoms started recurring. Even when it is taper or abrupt, the symptom recurrence was severe. So the hormone therapy treatment, the decision to continue was still in a dilemma among the gynecologists. So it depends on the benefit risk profile. Absolute risk in healthy women, like below 60 years, it is okay. But long-term initiation in older women has greater risk. Breast cancer risk is increased. So when the menopausal women are undergoing treatment, what are all the screening tests we can give? One thing is blood pressure at least every 2 years, if normal. Bone mineral density, we can involve an orthopedician in that case. Cholesterol regularly if they are at the risk of heart disease. Colonoscopy, fecal occult blood test, or sigmoidoscopy at the age of 50. Fasting blood sugar, we have to regularly monitor. Mammogram every 2 years at the age 50. Pap test every 3 years or every 5 years if it is combined with HPV, like liquid-based cytology. Pelvic examination yearly. And STD infection, actually both partners including HIV before initiating the sexual intercourse. So we have to monitor these women and they are in HRT treatment. So what are the alternatives? So we have, since we have seen many risks involved in this hormonal therapy, we have to go in for other alternative methods. So they have come up with many complementary and alternative medicine like soy isoflavone, traditional Chinese medicine, herbs like black cohosh, cranberry, St. John's wort, valerian, and vitex. Over-the-counter hormones like dietary supplementation like topical progesterone and melatonin. But though they have relieved the symptoms to some extent, it is not fully addressed the problems in the menopausal women. So as we have discussed, the life women started to adapt their lifestyle changes like tried relaxation techniques like yoga, meditation, eat a healthy proper diet with increased fluid intake, get regular exercise, avoid hot flush triggers like excessive intake of caffeine, alcohol, and spicy food. Keep cool by dressing in layers like using cotton cloths, sleep in a cool room, consume cold drinks. Reduce sexual discomfort and increase the sensitivity to moisturizers, lubricants, and vibrators. So we have to come to an ideal menopause solution. So this high estrogen content with HRT and also combining with estrogen pose a great threat to women's life. Similarly, the lowest dose of estrogen in phyto supplementation like soya flavin, this that doesn't address much of the symptoms of menopausal women. So, ideal menopausal solution should regulate an endogenous estrogen to non-reproductive organs. Similarly, it has to reduce its uh, receptivity in reproductive organs. So, the estrogen affinity to estrogen receptors, there should be upregulation of estrogen receptor to the non-reproductive organs, and there should be a down regulators in the reproductive organs, breast and endometrium. So there should be significant increased E2. So the external supplementation of estrogen to correct menopausal symptoms should be avoided, because we have gone through a study of Women's Health Initiative, but it should at the same time should offer symptom relief and without the risk involving like cancer, breast cancer, venous thromboembolism, and stroke associated with HRT. So we should find an ideal menopausal solution. These are all the comparison like HRT and isoflavins. This conjugated estrogen, estradiol, estradiol replace strong estrogen, but it has many risks involved. Isoflavins like phytoestrogen, soya isoflavin, zenistin has some amount of estrogen, but this estrogen is very weak, so it couldn't address much of the problems which the menopausal women face. So the ideal solution should regulate an endogenous estrogen, which should have an estrogen affinity to estrogen receptor in non-reproductive target organs, but it should downregulate the estrogen affinity to reproductive target organs. Like non-reproductive target organs like vasa endothelium, so that it can reduce hot flushes, night sweats. CNS, it can improve the mood swings and insomnia. And bone, it can improve the bone mineral density. That's why reducing the risk of osteoporosis. Similarly, downregulation of estrogen receptor in breast and endometrium. So there will be no proliferation of MCF7 cells. So there will not be a risk of cancer. So it doesn't replace strong or weak estrogen, but it regulates the estrogen affinity to the estrogen receptors. So in all the phases of menopausal transition, like in the perimenopause, menopause, and postmenopausal women, this addresses all the transition women. A perfect menopausal solution will be estrogen 100 1 beat. Actually, they have considered many studies in using this oriental phytochemicals. Actually, it is found in Korea and China. Synanchum wilfodi, which contains cinnamic acid, Flomis ambrosa, which is an methyl ester, and Angelica gigas, which contains digoxin. So when I googled these topics, we have found out with these beautiful herbs where they all have this and apoptotic features. They have decreases the risk of thromboembolism. It has high antioxidant properties, and it regulates the thermal metabolism. That's why this hot flushes gets really gets relieved. I have seen for the past 2 to 3 years, I have been using this estrogen. Or even with OD dose, when we give, the patient gets really relieved of the symptoms of vasomotor flushes, night sweats, and this mood swings within for 35 to 40 days of starting the treatment. So they have no effect on estrogen receptor alpha and beta, and at the same time it inhibits MCF7 cells. That's why it decreases the incidence of breast cancer too. So they have conducted 3 randomized placebo-controlled trials, one conducted in USA and 2 in Korea. Both were like validated and published in renowned journals. When they did the study, the estrogen 100 group compared to placebo group had significant reduction from 10 out of 12 Cooperman index symptoms, which we have addressed already, like vaginal dryness, hot flashes, mood swings, and bone pain relief symptoms within 7 to 14 days. So effect on long-term menopausal events, like there is no activation of carcinogenic cells, benefits on cardiovascular disease and severe parameters. There is decreased MCF7 cells, that's why it decreases the cancer risk, decreased CVD and stroke risk, decreases the cholesterol metabolism, decreases LDL and triglycerides, and increases the HDL. There is no effect on hormone like estrogen receptor beta, no increase in estradiol, no increase in FSH, and no increase in growth hormone 2. So similarly, when we conducted the study, there is effectiveness when we address this bone mineral density. There is after when we compare the women prior to treatment and after 1 year, there is significant increase in bone mineral density. That's why the risk of fracture and the risk of osteoporosis in this women declined after the usage of estrogen. So it is given in all the phases of menopausal transition, like premenopause, perimenopause, menopause, and postmenopausal women. There is significant improvement from hot flashes, vaginal dryness, and mood swings. Similarly, the climactic symptoms got improved. The female neck bone mineral density was increased. Serum triglyceride level became low, and human growth hormone didn't get altered without weight gain or any serious side effects which we encounter in hormonal treatment. So when we give at higher doses also, even at 2 gram per kg body weight, there is no toxicity we have observed, and there is no mortality found in this estrogen 100 women. So it is very well approved in US, Canada, Europe, Asia, FDA, everything has approved this estrogen 100. So to help women free them from hurt. So it is an effective, safe, non-estrogen component. We have to we should not let the women don't regret growing old. It's actually privileged to be to be on the safer side. You have to when we counsel this menopausal women, we have to listen to them, respect and validate, support them, and build trust. So on the trust should be built only with the ideal medication which we can prescribe to the menopausal women. So with this I conclude my speech. This has proved to be, with my little clinical knowledge and my experience, this estrogen was found to be a really wonderful drug when compared to hormonal treatment or with soy supplementation. Thank you very much for this wonderful opportunity to address the gathering and to connect with all the fellow gynecologists throughout India. Thank you so much.
Thank you, madam. Thank you for this nice talk. And meanwhile, I have received a few questions. So if you allow me, then I can.
Yes, sir. Yes, sir. Sure.
So, ma'am, my first question is, what is your think on that yoga and meditation, can it help in menopausal symptom?
Obviously, sir. Actually, it's the mind that controls. Actually, the menopausal women, as actually they suffer from more mood swings and dementia and Alzheimer's. So definitely, this yoga and relaxation techniques will help in them to some extent. Definitely, obviously.
Ma'am, in HRT, how long you prefer to treat with HRT in case of a menopausal patient?
If we have to start low and go slow. And similarly, it cannot be prescribed too long also. So it has to be taken early. It should not be taken after 60 years. So if at all we have to give HRT also, it should not be prescribed for more than 5 years.
Okay, madam. And if one patient come at an early age, we say around 40 years of age, and she is having some menopausal symptom. So in that case, what you would like to prefer first to treat them?
Perimenopausal women with like when they don't have much high risk, when she is not obese, when she doesn't have any risk of CVD or breast cancer, we can start them on hormonal therapy, provided we have to follow them up with so many tests. When it is given early, the benefits of hormonal therapy is more, but when it is given late after 50 years, it is very difficult. It has the risk outweigh the benefits when it is started late.
Okay, madam. And another question is, ma'am, alternate therapies in the case of it is if it is phytochemical based. What do you think? How it is safe in that particular single patient?
I didn't get you, sir. Phytochemical based?
Phytochemical based products as an alternate therapy. How is it safe? What is your practical idea? Means practical.
Phytochemicals in the sense you are asking this black cohosh and
Yes,
soy
ma'am.
supplements.
Yes, ma'am.
Actually,
Yes.
that is like a natural supplement, like a dietary supplement. It doesn't create any risk when we give phyto supplementation, but it doesn't prove much benefit also when compared to this good drug. That's what we feel.
Okay, ma'am. And another question, ma'am. In younger women,
Yes.
are they complaints with some estrogen therapy?
It's very difficult, sir. We have to be like, we have to listen to them. Like each woman has to be individualized. We have to tell their risks, benefits, and like regarding, we have to counsel regarding the continuation of therapy. That is more important. When they when they take intermittently, they won't get their benefits also. They will get breakthrough bleeding. They will have all the risks also. So it has to be like a risk and benefit. Both should be like counsel to the women before starting any treatment.
Yes, madam. That is risk-benefit ratio you are talking about. I think so. And ma'am, in that case, if you face any difficulty while using the estrogen in that young woman, so what will be the alternate treatment approach in that case?
Like 40 years. Like
Yes.
depending on the symptoms, sir. Like when they come with like hot flashes or something, like we can like even in this 3 years I have like given in estrogen perimenopausal group also.
Okay.
When we give estrogen for like 20 days estrogen BD also, they definitely the symptoms get resolved, and they itself they come and take the medicines regularly when they see the benefits.
Okay, madam. And madam, I could not find any other question in our dashboard also. So if you allow me, we can close today's session.
Sure, sir, sure.
So thank you very much, ma'am. Thank you for your valuable time here, and we look forward for your contribution as well in our platform also. So thank you, madam. Good day.
Thank you so much, sir. Thank you once again to the all the team members and all the viewers who have patiently listened to this lecture. Thank you once again.
Thank you
Thank
very
you,
much.
ma'am. Thank you, ma'am. Have a good evening ahead.